Hello and welcome to the Clinical Update podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Pat, editor of MIMS Learning, and I have with me today our medical editor, Sangeeta.
Hello.
Today we're going to talk about some really helpful case studies on mental health, which will help GPs to better support their patients. So you're aware, before we get into our discussion, we will today be covering how healthcare professionals can support people who may be considering self-harm or suicide to help keep them safe. At MIMS Learning, we bring together bundles of learning modules into what we call learning plans. We've just launched a whole new set of learning plans, drawing together CPD in related areas, adding to the plans we already had. These plans fit with GPs' personal development plans in which they nominate particular areas where they've identified learning needs. You can get between 4 and 10 hours of CPD for an individual plan, depending on its length. One of our new learning plans is the Adult Mental Health Learning Plan, for which we've gathered together a suite of learning materials written by Professor Carolyn Chew-Graham. She's a Professor of Primary Care Research at Keele University with direct experience of GP practice. Let's look at some of the case studies featured in the modules that make up this plan.
The first case study comes from a module on the psychological effects of cancer. Obviously, living with cancer or caring for someone with cancer substantially affects people's well-being. But in the case of Kay, who is 58 and has been given a breast cancer diagnosis, circumstances are difficult. She is the sole carer for her adult son, who is autistic and has behavioural problems.
That sounds really challenging for Kay. So what's the recommended course of action for the GP in this case?
So according to Professor Chew-Graham, the GP should consider how Kay may be feeling and whether she'll have concerns around looking after her son while she has treatment, and what would happen to her son if she died. If immediately concerned for Kay's well-being, the GP is recommended to contact her straight away for an appointment to discuss how best to support her. If not immediately concerned, an offer for an appointment should be made within 3 months. Professor Chew-Graham says that the risk of suicide among people with cancer is higher than that among the general population for certain diagnoses associated with a poorer prognosis, especially in the first 6 months after being diagnosed. This is according to research from JAMA Psychiatry among UK patients, which describes the 6 months after diagnosis as a critical period requiring greater vigilance for psychological distress. In fact, those researchers say that the first week after diagnosis has the highest risk for suicide, which reduces thereafter.
That's interesting about the first week. So if concerned, the GP may want to contact the patient sooner rather than later. In any event, GPs should offer a cancer care review to all patients within 12 months of cancer diagnosis. And Professor Chew-Graham recommends allowing 30 minutes for this review if possible and sending a questionnaire beforehand to gauge the patient's needs. The patient should be encouraged to bring a friend or family member, and the GP should explore their mood during the consultation.
It might be difficult for GPs to find time for a 30-minute appointment.
Yes, I agree, particularly in the current climate. So are there any potential solutions?
Well, there is an article in the British Journal of General Practice by Dr. Sandra Dyer and colleagues about cancer care reviews, and it makes some suggestions. It recommends allowing a little longer for appointments, ideally a double appointment. Other options might include a follow-up appointment and/or referral to another primary care team member or a cancer care coordinator if available. In this journal article, the authors recommend avoiding jargon during the consultation, acknowledging the life-changing impact of a cancer diagnosis, and trying to maximize continuity by having just 1 or 2 clinicians following the patient on their cancer journey. I spoke to Dr. Sam Finnegan in the last episode about shared decision-making, and we discussed this exact same issue, how to overcome the time constraint that GPs have. He discusses how continuity can be such a powerful tool for a GP. Knowing about a person's circumstances and preferences allows you to hit the ground running, and it could help a GP make a lot more progress in a shorter consultation.
Yes, continuity of care is such a great idea anyway, and even more so in the cases that we're discussing, I think. So staying with the module on psychological effects of cancer for just a little longer, there's another case of a man who's 62 years old and he's called Paul, and he had surgery for stage 1 bowel cancer 2 years ago. He didn't require chemotherapy, but now he presents to his GP saying that he no longer knows what a normal bowel habit should be like for him and whether he should be concerned about having loose stools. He then admits that he gets really, really worked up before attending follow-up tests at the hospital.
Professor Chew-Graham describes this as scanxiety, fear and worry before a medical appointment about what tests might reveal. This is associated with depression and anxiety.
This resonates with the experiences of patients who talked to Rhiannon late last year on the podcast about their breast cancer journeys. And one of them said that when you've had that diagnosis, your health anxiety is lifelong. And so even just walking into the GP surgery made her feel very anxious.
Yes, that podcast episode was really interesting. And we'll put a link to it in the show notes. Do have a look at Professor Chew-Graham's module if you get a chance. One learner gave the following as feedback. I think it's really important that all primary healthcare professionals undertake this module. And another said it was very informative and asked for more case-based courses.
Great to have that feedback. So let's have a look at another module from this learning plan. Again, this is case-based and deals with the important subject of assessing the risk of self-harm and suicide in primary care. Professor Chew-Graham asks us to consider two hypothetical presentations to a GP practice, Lucy and Lowell. So Lucy is a 19-year-old student who submits an online query that states she's feeling very depressed and needs help. And Lowell, on the other hand, is a 42-year-old man who presents at the practice reception asking for an urgent appointment because he can't cope.
As well as asking GPs to consider how their practice staff and systems would respond to each of these queries, Professor Chew-Graham provides a strategy for assessing the risk of self-harm and suicide for individual patients. She says it's essential to take a person-centered approach and to assess current or previous self-harm behavior and mental health problems.
After that, the GP should move on to assessing thoughts, plans, and intent. Is the patient expressing feelings of hopelessness? Are they saying that they wish they were dead? The GP can take a direct approach to questioning, asking, have you felt like harming yourself? Do you ever feel that you would be better off dead? Or they can take what's termed a normalising approach, saying, sometimes when people are feeling distressed, they think of harming themselves. Is this something you've been thinking of? GPs should find out what stops the person harming themselves, that is, the protective factors in place such as family, and consider referral to a crisis team or home-based treatment team, as well as offering proactive follow-up. This can help the person to overcome the crisis.
Professor Chew-Graham says it's important not to use risk assessment scales to predict self-harm, repetition, or suicide risk, as there are no validated scales for this.
That's useful to know. And I came across a suicide prevention communication toolkit from NHS Practitioner Health online, and this gives some guidance on conversations around suicide and mental health. And this stresses that asking directly does not increase risk. It can be a relief for the person to talk openly and be heard. And they signpost a papyrus guide, how to have difficult conversations about suicide and mental health, which may be helpful. And NHS Practitioner Health says that if you're worried about a colleague, don't ignore it, take action. Speak up, either raising it directly with them or with another colleague.
Yes, they say that showing you care, I'm worried about you, can make someone feel seen, and listening without judgment is important.
Absolutely. I think listening is a vital skill, both within consultations and also when talking to colleagues who may be at risk.
But what about the times when you don't even have the chance to talk to your patient? I'm referring here to the times when patients do not attend appointments, meaning they miss out on opportunities for support and intervention.
Yes, Professor Chew-Graham provides some insights in another module into why patients miss appointments. And no surprise here, she says this may be linked to mental health conditions such as schizophrenia, anxiety, and depression.
This module is called Why People Miss Medical Appointments and How to Support Them, and it outlines some case studies on what she terms missingness. Very broadly, she says there are 3 types of barriers that can lead to the dreaded DNAs. First, people can believe that primary care is not relevant. They don't feel the need for their routine appointment or feel that what primary care is offering is not for them, or they may have low expectations around their health and or fear, worry, shame, or anxiety about it. Second, there are competing demands on people's time. They have lots of competing priorities or multiple conditions with lots of appointments or caring responsibilities or difficulty meeting basic needs. Third, social constraints may be in operation, such as negative prior experiences of seeking care, feeling excluded, and or wider experiences of trauma, stigma, or discrimination, which leave them feeling mistrustful of healthcare providers. There may also be more practical issues around getting to appointments, cost of travel, and or limited mobility.
Some specific examples of some of these factors at play include the case of Tony, who's 26 and has schizophrenia. He's been discharged from mental health services, but he's missed 2 appointments for an annual physical health check. And Professor Chew-Graham in the module asks GPs to consider what their practice can do to encourage Tony to attend. Could a phone call from a clinician help? What follow-up is there if he doesn't attend? And has someone explained the importance of the checks to him?
There are probably no easy answers, but it sounds as though personal contact from a team member could be a recommended route. Text messages are easier to ignore.
In another case, Andrea is 46 and has struggled with anxiety and depression for much of her life. She doesn't attend an appointment with a GP that she doesn't know because she predicts the GP will just ask about her drinking and prescribe antidepressants. And again, there's a challenge from our author. What does your practice do to offer continuity of care for Andrea and people like her? Given that antidepressants should only be prescribed for more severe depression, what are the alternatives for Andrea? Is there a role for social prescribing, services that offer support for alcohol misuse, and/or talking therapies?
Lots to consider there, and a challenge for GPs who are pressed for time and seeing a lot of very complex patients.
It certainly is, but other team members can help. For example, the practice may have a DNA protocol to describe how DNAs should be responded to, and that would involve other staff. The module has more case studies, including Aisha, who's a carer and feels she can't leave her husband alone to attend appointments, and Mark, who's just been released from prison. It's well worth a read, along with the other modules in the plan. And what are some of the highlights of the rest of the plan, Sangeeta?
There is the issue of frequent consulters in primary care. This is a real challenge, and Professor Chew-Graham provides tips on how to deal with it. Polypharmacy in older people with mental health problems. We've talked about this one in a previous podcast, and it's a good case-based look at how to help older adults who are on a lot of medication. Eating disorders in men. An interesting one because we often think of eating disorders just affecting young women.
Great, and there are more modules as well. Professor Chew-Graham takes a very GP-centric view, rooted in the realities of clinical work and practice organisation, so there's lots of good reflection and learning points for GPs and other primary healthcare professionals. So do check out the learning plan, especially if you've identified mental health as one of your learning priorities. It's available for purchase or as part of the MIMS Learning subscription. What have we learned today? Firstly, what I take away from this is the importance of teamwork and continuity in general practice, of vital importance here in the area of mental health. So these learning modules in the plan have a common theme of discussion and decision making about how the whole practice approaches the needs of individuals. Secondly, the 6 months after a cancer diagnosis are a critical period requiring greater vigilance for psychological distress, and the first week after diagnosis has the highest risk for suicide, falling thereafter. Third, asking directly about suicide does not increase risk, but it's important not to use risk assessment scales to predict self-harm repetition or suicide risk, as there are no validated scales. Thanks for joining me, Sangeeta, and thanks for listening today. We've been the MIMS Learning editorial team, and this episode was produced by Jude Owen. Don't forget you can see key learning points and claim a CPD certificate for listening to this episode if you head over to the MIMS Learning website at mimslearning.co.uk. Join us next week for more clinical insights from MIMS Learning's expert writers and speakers.